Hi, Sam here, and I am submitting my third assignment, and for this I chose to do a video primer. So the objective of this assignment is to outline some strategies that are suggested by the JAMA User's Guides to Medical Literature to avoid being misled by biased representation and interpretation of data. And it's important to note that I'll specifically be looking at randomized trials results for this. So, the User's Guide, or JAMA as I'm going to refer to it, suggests 8 ways to avoid being misled by study results. The first way is to read only the methods and the results and bypass the discussion section. Now, I find that this is the most intuitive and one of the easiest ways to avoid being misled because it actually takes less time than reading the whole paper. And also, when you read both the methods and then the results, it can tell you whether the authors use the intention to treat population or the per protocol population, which is very important. But regardless, the discussion and conclusion is where most of the spin happens in a paper, so although you probably won't avoid all of the potential spin, you can avoid most of it by reading just the methods and the results sections. So, the second method is to read the abstract reported in evidence-based journals, or secondary journals rather. Now these journals use individuals with a low risk of conflict of interest to create structured abstracts. And these abstracts are written after a critical appraisal has been done, and the abstract then reflects the study's results in light of this appraisal. So although this isn't a perfect strategy, it may save time, and it may just give you an extra perspective that you maybe hadn't considered in the first place. So the third strategy they outline is to beware large effects in trials with only few events. So for this, I want to point out that there are 2 factors that affect the effect size found in a trial. The first is the number of people in the study, or the denominator, and the second factor is the number of events, or the numerator. And the latter is more important for effect size. So therefore, a study that has a large effect size estimate with a small number of events should be interpreted with caution. Now the fourth strategy rather that they suggest is to beware of faulty comparators. And now this relates to the control group of the study. So the intervention given to this control should be the standard practice. So if authors are comparing their intervention to placebo when there is an effective treatment in existence, this is a very large caveat for this study. So not only is this unethical, it is very likely to produce a statistically significant treatment effect because the intervention is being compared to nothing. For the intervention in the RCT, to be done on this intervention in the first place, we already expect it to be better than nothing. So comparisons to placebo are fine if there's no other available intervention or the current gold standard of practice is to do nothing. But generally speaking, we should be looking for the best intervention that's possible to be our comparator. So this obviously is different if there's genuine equipoise or uncertainty within the community about whether the drug standard of care or the placebo is best. So the 5th strategy that they outline is to beware of misleading claims of equivalence. Now this has to do with a subclass of randomized control trials called non-inferiority trials. These are trials in which the intervention is a drug that is cheaper, less invasive, etc. than the current standard of care. So the comparator here is the standard of care, and the difference between non-inferiorities and the classic randomized trial is that here the hypothesis is not that the new intervention is better, but rather just that it's not worse. So a simple way to sum up this point is to say that if the intervention is equivalent to a useless comparator, then both drugs are useless, and the fact that they're equivalent is meaningless. So I think that's what the JAMA authors are getting at when they say to beware of misleading claims of equivalence. So the 6th point that they bring up is to beware of small treatment effects with extrapolation to low-risk patients. And now this has to do with some trials will use high-risk patients who have a higher chance of success with an intervention simply because of the severity of their condition. So in other words, in the case of high-risk patients, benefits may outweigh the risks because they may have died otherwise or had serious complications otherwise or something of that nature. But if these results are then extrapolated to lower-risk patients, the risks could outweigh the benefits for this group. And this could be because the patients didn't have that high chance of death or complications or what have you to begin with. So this illustrates an important point. When interpreting a randomized control trial, the first step should always be to identify the research question, or the PCOS. And you want to then keep this patient, or the P of PCOS, in mind when interpreting these results, and then you have to make a judgment statement regarding the external validity of the study. So the 7th strategy is to beware of uneven emphasis on benefits and harms. Now this is another issue surrounding spin, and I think it's pretty self-explanatory and doesn't really need to be elaborated on, but the only important thing to note here is that when identifying the PICOs at the start of reading the study, choose outcomes that are patient important, and do try to classify these outcomes into benefits and harms. And this way you'll be able to get a clearer picture of the balance of the benefits and harms. So the last strategy suggested by the JAMA is to wait for overall results to emerge. Don't rush. Now, ideally, we should be waiting for enough studies to emerge that together paint a picture of the possible range of results the intervention can have. And basically, I like to think of this point as an example of regression to the mean. The first few studies may have random highs or random lows, but once more are completed, the studies will begin to center around an effect that's more likely to represent the true effect. So it's important that we just don't rush into anything as much as we might really want to, or we might think this new intervention could be really great. If we're not 100% sure, then we need to wait until we have enough studies to do that. Now, those are the 8 that the JAMA suggests, and I would actually like to add one of my own. I think that to avoid being misled, we should check the clinical trials registry before reading the paper. And that's because this way we can know what the outcomes were, how many patients we plan to enroll, how much the follow-up was scheduled, etc. Because sometimes the outcomes aren't very clear in a paper, and this can help make sure that authors didn't add outcomes after the study was done to fish for significance. And it also helps because that way you'll know whether a study was stopped early. Now this is important because reading the registration will allow you to determine this, which is very important to know. And sometimes it's unclear from reading the paper. All right, so those are 8 strategies suggested by the JAMA to avoid being misled by biased representation of results, as well as one of my own. Thank you very much.